Hello, everyone, and welcome to all who are tuning into this live broadcast, wherever you're joining in from all over the world, whatever the time zone you're in at this time. For some of you, it's morning, for some of you, it's good afternoon, for some of you, it's good evening, for some of you, it's good night. Today, over this session, we'll be talking about a very interesting topic as entitled When It's Not Your Thyroid. When it's not your thyroid. But before we go any further, we have to understand what exactly is the thyroid gland. So, the thyroid gland is a very powerful organ located in the neck, just in the front, and it's partially hidden by the strap muscles. It's not usually seen or felt, and I will add here that when you can see and feel a thyroid, that obviously means that the thyroid is enlarged. So without going into any great anatomy, any great anatomical detail, simply put, it's a bow tie shaped organ that chiefly produces the thyroid hormones. These thyroid hormones are thyroxine, which is otherwise known as T4, and triiodothyronine, otherwise called T3. And these hormones serve a wide range of function. Their major role is to control metabolism. So therefore, if your thyroid hormones are very low, you can have a slow metabolism. If they're too much, you can have a fast metabolism associated with weight loss as well as other complications. Now, thyroid hormones regulate activities in all major organ systems of the body. So when your thyroid is working optimally, you're totally unaware of its presence. You actually feel fine. When it's underperforming, that's when you notice. When it's either underperforming or overperforming, that's when you observe that there is a problem. That's when you can tell the difference, that there's something going on in your body. Now, the focus of this broadcast is to give an introductory overview of low thyroid functioning, which is also called hypothyroidism, and to also transition from that to our main topic, when it's not your thyroid. This is a very important point here, because hypothyroidism can be wrongly diagnosed instead of making another diagnosis for another entity present. And many of the symptoms of hypothyroidism are also the symptoms of other underlying medical conditions. It is also very true that hypothyroidism can coexist with other entities. So, wow, just think about that. It does not get easy for me as the endocrinologist, as I listen to my patients, as I try to figure out what is going on with their care, to decide what is making them unwell and how we can come together to make a treatment plan that will be to their benefit. So, it has been found in community-wide surveys that overt hypothyroidism represents approximately, or we could say less than 1% of the population. These are the patients who have the severe symptoms of hypothyroidism. And I'll be getting into what those symptoms are in what we call sub as patients who have overt hypothyroidism. Both groups of patients respond to treatment usually. Most forms of hypothyroidism are related to defects at the level of the thyroid, but then there's also something called central hypothyroidism, which has to do with hypothyroidism that occurs because at the level, at higher centers, the brain, the pituitary and the hypothalamus in the brain, they control the thyroid. And problems there can also cause low thyroid function. So, what are these symptoms of hypothyroidism? What are the symptoms and signs of of a low thyroid function? Well, many of these symptoms, as I said before, they are not specific to um, hypothyroidism on a whole. These symptoms can include fatigue, which is just pure exhaustion, cold intolerance, sleeping too much, which is hypersomnolence, constipation, weight gain, and sometimes these patients could, our clients could have an enlarged thyroid. I must say here that a client can have an enlarged thyroid because of a number of other medical problems. So as it pertains to the skin could be pale and cool. There could be decreased sweating. There could be coarse hair. There could be a phenomenon called um, a non-pitting edema. When you make an indentation on the skin, you realize that the skin does not, when you try to make an indentation, the skin does not pit. The skin around the eyes could look puffy. There could be anemia or a low blood count. There could be an anemia or low blood count. It seems that my connection is unstable. So let me continue with the video. So there could be anemia. Women may have heavy periods and even iron deficiency anemia. There could be heart and circulatory system problems. There could be low cardiac output with decreased exercise tolerance. There could also be hypertension. Hypothyroidism is a known cause of hypertension, though not the most common cause of hypertension, high blood pressure. Hypothyroidism can also cause lipid abnormalities such as high cholesterol and high triglycerides. For the respiratory system, it could cause sleep apnea because of a large tongue. As it pertains to the digestive system, it can cause constipation and poor taste. Patients may have a thinned stomach lining, what we as doctors call an atrophic gastritis, because they may have parietal cell antibodies. Patients with hypothyroidism can also have celiac disease or gluten intolerance, and this is 4 times more common in hypothyroidism than in the general population. Patients with hypothyroidism can also have non-alcoholic fatty liver disease. As it pertains to the reproductive system, as I mentioned before, many of these patients can have heavy periods or even cessation of menstrual cycles altogether, leading to infertility. They could also have decreased libido and delayed ejaculation. As it pertains to brain and central nervous system problems, patients with hypothyroidism often complain of poor concentration, poor short-term memory, Sometimes they say, Doc, it's like my mind is in a fog and I can't extract what I need when I need it. So the question is, how do we make the diagnosis and how do we treat these patients? So the diagnosis is made by the patient having a constellation of symptoms. They may have a list of these symptoms that we just mentioned, or and they will also have the lab abnormalities. They have lab evidence of a problem. Most cases of hypothyroidism, as I mentioned before, are due to what we call primary hypothyroidism, meaning problems at the level of the thyroid. The most common cause in the United States is something called Hashimoto's, which is an autoimmune defect at the level of the thyroid, which causes the thyroid not to produce enough thyroid hormones. And I also mentioned central causes, which could be problems at the level of the brain, the hypothalamus, and the pituitary. So most times, as a provider, I have to check in what's called a TSH test. And if the TSH is elevated, in the cases of a problem at the level of the thyroid, then I can say, with the associated symptoms, I can say that the patient has hypothyroidism. I will also check the T4, the free T4, and the total T3 levels, and that will help clue me in if there is a central problem, since the TSH may be normal when there is a central problem, normal or low. So each lab has its own reference ranges for what is considered normal or abnormal. So once a diagnosis is established based on what the patient says and what you find on examination, meaning the clinical features, plus the lab investigations, once you have established the diagnosis, then treatment is recommended and prescribed. Treatment is usually with levothyroxine, which most times comes as a generic formulation or branded formulations. Generic formulations are more affordable or more cost effective for the patient. Most patients who need treatment benefit from generic formulations. There may be circumstances where I may use branded formulations, such as the gel formulations instead of the tablets. For example, in patients that I'm treating for with atrophic gastritis, I mentioned the thinning of the stomach lining early on, or if they have had weight loss surgery and they have a smaller revised stomach, those patients may benefit from some of the branded formulations. There's also something very important to note here in the treatment of a low thyroid or hypothyroidism, and that is levothyroxine is T4 replacement. That levothyroxine is a pro-hormone, which the body will convert to T3. So there may not be any need for us to give both hormones, just T4 alone as levothyroxine may be sufficient. In some patients, and I will talk about this a little later, they may need T3 as well. Note well, if a patient comes to me for the consultation, they're not on treatment and their thyroid function tests are normal, I'm going to immediately assume that their symptoms are likely due to another diagnosis, which is mimicking the symptoms of a low thyroid. In this case, someone who doesn't qualify for treatment of hypothyroidism, treatment with levothyroxine could be inappropriate or may be even dangerous, since over treatment or inappropriate treatment can have adverse side effects. Still, there are some patients that do not feel relief of their symptoms even with levothyroxine. And these patients, I will offer desiccated thyroid extract, which comes from bovine or cow sources, or porcine, or from pig sources. And these formulations, one such formulation is called on thyroid, and sometimes we have to make a switch from levothyroxine to this desiccated thyroid extract, and then the patient's symptoms improve. But not very commonly. Most patients respond to levothyroxine alone. And usually my patients, once I start them on treatment, they're reviewed initially after 4 to 6 weeks. We ensure that the symptoms have subsided and that their labs are normal. And then once we are convinced, both the patient and I, that they are on the right path, then their follow-up intervals are extended. Another thing I always ask my patients to do is to always to check their pill bottles or pill packs to see what generic formulations of levothyroxine that they're on. I always want them to make a note of who their manufacturer is, and this can be found in fine print, either at the bottom center, bottom left, or bottom right of the container, or on the packet labeling. This is important as I have found in clinical practice that patients have sustained relief from their symptoms of hypothyroidism if they stay with the same manufacturer. I find that I don't have to call them often to check labs and make frequent changes, and this contributes to the patient's quality of life. I have found that different manufacturers add different ingredients to their tablets other than the levothyroxine itself. Many of these ingredients aid with the delivery of the active ingredient itself to the systemic circulation. It's best to stick with one manufacturer for optimal results. So, wrapping everything up in a nutshell, when you come to see me as an endocrinologist for the management of your low thyroid state, I am not only going to validate your concerns that you could be right and you're likely right about your diagnosis, but I'm going to be very broad in scope initially because as a doctor, I'm always very wary of avoiding what is called anchoring heuristics. Because when you anchor on a singular diagnosis and you're set and you're fixed and you have a tunnel vision and you are not prepared to entertain other possibilities, you may miss a totally different issue, prescribe inappropriate treatment, and you may even miss a coexistent problem. Some coexistent problems could even be worsened by treating the hypothyroidism initially. And it's also very important that I manage along with the patient the doctor client expectations. That these are managed very well because if the patient trusts what I say and is able to implement the management plan, and I'm able to listen to my patient to know what's working and what's not working, then in such a setting, patient will get the appropriate outcomes that they're looking for. So when we say when it's not your thyroid, there are other diagnoses which may look like the thyroid, like it's hypothyroidism, and they may share common features. Some of these include heart failure and coronary artery disease. These patients present with fatigue and exercise intolerance, which can happen in hypothyroidism. What about patients with COPD, patients with asthma, patients with other chronic lung conditions? They can also have fatigue and exercise intolerance. Consider patients with chronic kidney disease, especially those who are at the advanced stages like chronic kidney disease stage 4. How about those who have obstructive sleep apnea, either untreated or undiagnosed? They can have fatigue and daytime somnolence, which can mimic hypothyroidism. Consider patients with celiac disease. They can have the symptoms of hypothyroidism too, And it's always amazing to me that when I can appropriately diagnose these patients and put them on a gluten-free diet, that their symptoms improve without me having to overtreat or inappropriately treat a thyroid state. Patients with inflammatory bowel disease will need the help of a gastroenterologist. How about patients with anemias, be it nutritional anemias, inherited anemias, and acquired forms? We will need the help of our hematology colleagues to manage those. As an endocrinologist, I am always mindful of other hormonal disorders that can also mimic hypothyroidism. Disorders such as um, adrenal insufficiency, primary hyperparathyroidism, uncontrolled diabetes, or, or newly diagnosed or undiagnosed diabetes. All of those can mimic hypothyroidism, diabetes insipidus, hypogonadism, low testosterone in men. How about menopause, a low estrogen state in women who no longer have their menstrual cycles, which can be associated with subtle symptoms that mimic hypothyroidism. How about some vitamin deficiencies, like vitamin D deficiency and vitamin B12 deficiency? How about depression? Depression is can be a very stubborn clinical entity for primary care providers and mental health providers to treat. But depression symptoms are often identical to the symptoms of hypothyroidism. As a matter of fact, sometimes hypothyroidism and depression exist. Sometimes they coexist. How about inflammatory arthritis? Because I've had patients before with rheumatoid arthritis who complain of severe fatigue and thought they had a thyroid problem, checked their levels, their thyroid hormones were normal, and I had to interface with their rheumatologist to look at their treatment, whether the patient was compliant with their treatment or not, before their fatigue improved. I work with my specialist colleagues to have emerging issues with my clients addressed. Personally, for me, I never ignore my patient's symptoms because every symptom from every patient is valid. At the time of initial consultation, we may not know exactly everything that is going on, but at some point in time, after establishing this therapeutic relationship between the patient and I, ultimately we'll figure out what is going on. As a matter of fact, in my consultation, one of the practices I have is that I allow the patient to speak on his or her own for the first 2 minutes or so. If I need to ask questions to guide the conversations, I do, but I seldom do that because I believe in the first 2 to 3 minutes, the patient usually will tell you pretty much what is going on with them. You never want to out talk or of your patients or talk about your patients or make them feel that their concerns are not valid, because their concerns are valid and they're here to learn from me as much as I am present in the office to learn from you. So in summary, I do hope that this information has been helpful. Remember, before embarking on any plan of care, make sure you speak with your primary care provider, your healthcare provider. You and your healthcare provider, your primary care provider, will make that decision to see an endocrinologist if you need to be referred to see an endocrinologist. So your comments are welcome in the comment section. And until next time, you all take care and stay tuned because I'll be sharing a lot more in this forum. So here's Sheldon McKenzie, MD endocrinologist. You all stay tuned and keep checking this platform for more informative information. Take care and bye for now.